I am Erik, still a fourth-year resident, Kellogg Eye Center. I'd like to present a very interesting case that came to me when I was, well, you'll see what service I was on eventually. So a patient was sent in, I think 56-year-old male or so, sent in. He had the complaint of headache with visual changes. This presents a very broad differential in ophthalmology, so I won't go into the differential at this point. We'll just get into the exam. Well, actually, if you ask him in his history, what do you mean? What's this visual change that you explain? And he says, well, yesterday in my left eye, I started having these spirals in my vision. And it's just, he's like, those spirographs? You ever do those spirographs? He says, it looks like a spirograph. And I had a throbbing behind my eye at that time. So we take a look. Visual acuity in the right eye was 20/30, corrected to 20/25, left was 20/50. Pressures were normal. Exam was externally grossly normal. No RIPD here, which we always like to see because we know something's real. A slit lamp exam was relatively unremarkable in the anterior segment. Had early cataracts and anterior vitreous. We dilated him, and Schaefer negative, had some syneresis, pretty typical for his age. So here's a fundus photograph of the right eye. Nothing too exciting going on over here. However, that's not the eye of interest for us. Here's his left eye. We were able to pull this up on a screen and show him this, and he says, yeah, that's what I'm seeing. That's exactly it. So, has anybody seen this before? If you've seen it, please let me. Okay, so some people have seen this. So we see these, white bands that have this crisscross pattern across the entirety of the retina. We'll take a little bit look at the macula here, a little closer look, and you can see some heme, you can see a little bit of edema, but the same crisscrossing pattern. And here's a fundus autofluorescence as well, which kind of highlights it, just another neat view. Another thing to point out here is, if you can see, there's a little bit of heme down here as well, which wasn't evident on the previous pictures, but there was a spot of hemorrhage that was intraretinal at that point as well. Here's an OCT through the macula. And there's, as you can tell, a lot of subretinal fluid, a little bit of intraretinal fluid. And if we look closely here, if you look at one of these tracks, there's a little bit of subretinal changes there as well, but not as prominent as what's going on in the central macula there. So it's kind of a profound picture, something you hope to never see. And what we were able to diagnose this as was, it's called ophthalmomyiasis. Specifically, this is called ophthalmomyiasis interna. And this comes from ophthalmo-eye and myiasis, infection with fly larvae. So this patient, who had never left the United States, had evidence of a fly larva tracking in his subretinal space. This patient was actually sent to me. I was on the retina service, and it was sent in as possible Duzen, was the thought. That's kind of the small creature in the eye that we learn about in residency. This is fortunately just as rare, but nonetheless as profound. So what you may have noticed from the pictures is there was no fly larva. So the question begins, where's the fly larva? So on further talking to the patient, he says, I had these flashes with it, and then all of a sudden I had this flash right up here, just this little pinpoint flash, and then it was done. It's gone. So we did, full exam, scleral depressed exam. Our chair of, I found our chair of retina at Kellogg, Mark Johnson. He was very excited to find this. Came in, he did an exam, took a look as well, and we all agreed there was no larva. Not in the anterior segment, not hiding behind the iris, so we decided we needed to double check that. So did a B scan, looked for any sort of movement behind the eye, in the eye, looked at the anterior segment, and we're looking for this guy. They're about 2 millimeters in length, about a third of a millimeter in width. They're not small. They're not like Dusen, where you may not see them on an exam and you need your resident to sit there for 2 hours and track it down. If it's there, you're going to see it. And it's clearly not there. Some interesting finds on the exam, though, is here's an OCT. I believe this was through the inferior nasal retina. And we can see possibly a little track there that would have brought it into the vitreous. Again, no larva in the vitreous. And then on that autofluorescence, there's a track that's extending from all the posterior spiraling and moving more anteriorly. So we thought, okay, maybe this is a place that it could have exited. And then that hemorrhage that I noted before, here's an OCT slice through there, and it looks like there could be a track. So we've identified three or four different places where this larva may have entered or exited the eye. At this time, we considered a MRI. That was on our thought, or some people's thought, but the reality is we didn't think that it would have enough sensitivity to pick up an organic creature crawling around the eye in the orbit. So the question comes, what do you do at this point? One of our younger retina specialists said, if it was me, just enucleate, just take it out. And another one said, no, exenterate. And there was the argument of which one of those is most appropriate. The patient didn't share the same sentiment. So this is where he was when he first presented at the top there. Here's essentially the same slice at 5 days later. So this larva had been crawling under the retina. I think maybe found his home right in the central macula there, and made a lot of subretinal fluid. But 5 days later, it's essentially flat. There's some disruption in the outer retina there, but his visual acuity is 20/40 at this point. Again, at day 5, here's what the fundus or the Optos photo looks like as well. And you can see those tracks are dissolving. So we thought, all right, well, we'll send them to our oculoplastic specialist, who kind of agreed there's not much we can do. Maybe it's in the orbit, maybe it's in the brain, maybe it's out. We're not sure. So we just kind of monitored the patient. Until week 6, he comes and he says, my vision is getting worse. So take a look in the back of the eye, and we notice he starts to have some CNV that's developing without significant hemorrhage, and he also had some disc edema. So at this point, we thought, all right, maybe this larva's found a home, a new cozy home in somebody's eye. So we started the patient on a steroid burst for the disc edema and sent him to our colleagues in infectious disease, and they gave him a single dose of ivermectin to potentially treat a larva if it was still in there. Here's an OCT from the time, and he responded pretty well. That should say week 9, not week 6, but he now has some new lipid exudate. The disc edema is improving significantly, and he's complaining of or should say his symptoms are improving as well. So 4 months later, again, some CNVM, but it's regressing. Lipid exudate's improving. Disc edema is essentially gone at this point. And here's a picture from that same date. I share this because you can see the tracks inferiorly there, and this is what they looked like several months out and still look like to this day. And month 6, he's doing a lot better. Vision's back to 20/30, which is in line with the other eye. Actually, at some point during this time, he was seen by infectious disease. They noticed a strange bump in his eyelid and sent him in for an urgent evaluation for possible larva making home in his eyelid. It was just a sty, but we were kind of excited that maybe we found it. Fortunately, when this came to me, the fellow was surprised that I knew what it was. How do I get there? Let's see. And it's because this wasn't my first experience with fly larvae in my residency.
So I assume that it's scabbing on the front of the eye. Is it just poking through the front of the eyelid?
I mean, the lid itself is a very thin tissue. It's like one of the thinnest tissues in the body. So like, it's just increasing in size.
Try to mute it. So this is a human botfly larva that I saw in my third month of residency. This presented in a 14-year-old girl who was in Costa Rica, and this was sent in as a strange chalazion. But as I pulled the eyelid back, I noticed that the chalazion was looking at me. And, I was new to residency. I thought maybe that was just, normal, but turns out this is what was in her eye. And this is similar to what we were looking for in this patient. So, international or domestic, apparently this is something that can be seen. So keep your eyes for it. Look for that crisscross pattern. And I guess the question would remain, if we found the larva, what would we do? And what you do is similar to Duzen, you laser it. There's not a lot of case reports of this happening, but usually when you laser it, there's, as you expect, an inflammatory reaction. So you put the patients on steroids after. There's some argument of the role of ivermectin and its penetration into the ocular tissue, but most people agree that ivermectin is a good choice as well. Thank you.